Thank you, everybody, for attending the session. We have our chair, Dr. Bhanusena, with us, and our speaker. I'm Dr. Aparna Ahuja, the co-chair, and we have Dr. Walsh here. Thank you, and Dr. Holbik, who would be Dr. Johannes Holbik, who would be actually fielding questions on behalf of Dr. Tamara Seitz, who is not able to be with us due to certain unavoidable circumstances. And just quickly about Dr. Holbik, he is also in the same hospital, the specialist internal medicine and critical care at SMZ Sud. And Dr. Sinha, Bhanu Sinha, our chair, would you want to say something? And after that, we will initiate the live Q&A in whatever time we have left. And we will also take the questions which we cannot answer right now. We will send you a response for sure.
Thank you very much. Also from my side, a warm welcome to the discussion of this session. I am ECCMID appointed chair and working in the University Medical Center in Groningen in the Netherlands as a clinical microbiologist and doing some committee work also on the national committee.
Thank you, Dr. Sinha. Thank you so much. I'll just help the speakers by telling them the questions I can see in the Q&A chat box as well as the chat box. So there is a question, Dr. Walsh, which is for you, and I would say it's for you, which is about the technology and how sensitive are the T2 biosystem panels compared to blood culture. So there are questions on what, I'm just combining 2-3 questions. One is on what method is it and how sensitive it is. So, and what does T2 mean? Dr. Walsh, you are on mute, please. Can you unmute yourself? Yes, we can hear you.
Thank you. We'll first address the technology behind the T2 biosystem. It's easier to understand what it would take to identify an organism in blood culture. Typically, one needs approximately 10 to the 4th to 10 to the 5th organisms per CFU per ml for that kind of detection for culture. By comparison, one can, by the molecular techniques and the unique T2MR system, one can have 1 CFU per ml, 1 colony forming unit per ml, which is exquisitely sensitive. The sensitivity is enhanced by taking the 4 mLs of whole blood, bringing it into the system, a lysis of the organism, release of DNA, and then an amplification step, which is relatively rapid, in that as soon as there is an amplicon produced that is specific for one of the 5 major pathogens, E. coli, Klebsiella, Staph aureus, Epicedium, or Pseudomonas, we then there is a proprietary T2 paramagnetic probe which binds to the amplicon. When you have a paramagnetic probe binding to the amplicon, that then creates a change in the water configuration through a magnetic pole. For many of you, you're familiar with magnetic resonance imaging, where a magnetic field will basically alter the polarization of the water, and with release of energy, with the pole being restored, there is a burst of energy that gives a signal. That same technology that we use in MRI imaging similarly is used as the very sensitive signal, the alteration of the molecular structure of water, to give that very rapid detection, much more rapid than what you would have with a conventional PCR. So in that regard, one can see this alteration in the water structure using the paramagnetic probe through a magnetic resonance signal within the 3 to 4 hours. So it's that platform and to give us this with very unique paramagnetic and MR technology that can give us that information compared to, say, a conventional PCR system. So that's one. Two, and with that, then, how does that translate into sensitivity? If you look at the definitive, the pivotal Annals of Internal Medicine 2019 study by Dr. Nguyen and colleagues in more than 1,400 specimens, it was clear that for those organisms listed, there was 90% sensitivity depending on how one adjusted it for blood cultures. That sensitivity, though, is also understood in that in some situations one was even detecting more organisms than by conventional blood culture, which is always a challenge. If you have a very exquisitely sensitive system that is exceeding, quote, the gold standard, it's hard to call those false positives as well. But at bare minimum, one can say that the sensitivity was as good, if not better, and then truncated down to detection within 3 to 5 hours. That's certainly on the T2 bacteria. On T2 candida, T2 candida unequivocally detects more organisms in blood culture than blood culture. And we know from our earlier work that that blood cultures will miss easily 1/2 of cases with deeply invasive candidiasis. T2 candida unequivocally is superior to blood cultures, conventional blood cultures, in detecting significantly more cases of candida. The degree of candida really depends on the extent we've learned of deep organ tissue involvement, but certainly not only will T2 candida detect more than conventional blood cultures, but also, again, more rapidly within 3 to 4 hours.
Thank you. Dr. Holbik, I will just mention the questions I can see, and I'm going to combine 2, 3 actually together. One is basically about the screening protocol that was used for the COVID-19 patients in the ICU. And these are questions which are directed towards Dr. Seitz. So basically, how did you select which COVID-19 patients to test? And also whether the T2 panels improved outcomes in the hospital. So I'm just combining two questions together.
Thank you for the question. In general, every patient that is admitted to our ICU ward, we do normal blood cultures as per standard of the ward, and also we do swab tests for multi-drug resistant bacteria such as MRSA or Enterococcus, and this is done standardly with every patient. For the T2 panels, we wanted to see if there's some sort of super infection with patients that have already got like normal spectrum antibiotic on the general ward, and we wanted to see if the patient still has another infection. So we wanted to see if we can detect it, and we wanted to know if it's obviously if we can see it in a short period. So we did blood cultures and T2, as Dr. Seitz mentioned in her presentation. And well, yes, we saw with those patients with bloodstream-related sepsis, especially with central line infections, we saw quite good that the T2 panel was superior to the blood cultures, as we saw also with Candida. I think that the major selling point for T2 is Candida, since it takes a lot of time to grow Candida in blood culture, and it's also very difficult to detect. So for the question for selection, I think that the main part was a rise in white blood cells and also a new onset of fever after a certain time, since all the COVID patients, they have fever, and some have drug-related fever for the sedation. So, I mean, the major point was a rise in leukocytes, and also if the patient already has had a course of antibiotics. And well,
thank you so much. And Dr. Walsh, there's a question specifically for you. One is there any difference that you've seen in do you know about the data on incidence of co-infection, like in the low and middle income countries versus the high income countries? And what is the best approach to use the T2 panels for diagnosing these infections in the patient with COVID-19? Dr. Walsh, you're on mute, please.
I'm sorry. I do not have immediate access to comparisons of face-to-face, patient-to-patient of low and middle income to the higher income nations per se. I can't, however, I do work very closely with a wide range of colleagues and former trainees in the different countries, and have visited many countries, more than 28 countries across the world. And what I find ultimately is that when you take critically ill patients and they enter the intensive care unit, the biology starts to become very similar. The complications start to become quite redundant. The organisms may change, but given a set of risk factors, unfortunately, bacterial and fungal infections become universal. And so in that respect, targeting, especially when you have limited resources, targeting high advanced technology like T2 Biosystems to the highest risk patients, to those in whom you are likely going to have the highest yield, is a rational approach to be able to save resources. And what we have learned in the United States, and certainly in our own institution, but this has been seen in many places, is that in COVID-19, during that very early phase of the first week, that virtually all of the febrile illnesses are largely related to COVID-19. However, unfortunately, for those patients who go to unit with moderate to severe disease, within the first week, we start to see what the emergence of largely community-acquired organisms, such as pneumococcus, Staph aureus, Haemophilus, but into the second week and then expanding, we start seeing Klebsiella, Citrobacter, Pseudomonas, Enterococcus faecium. So one could envision then for the higher risk patients in resource-constrained environments that you would want to target T2 Biosystems for your critically ill patients with moderate to severe disease in the ICU. And that then, I believe, will be able to enable one to use the system, but still within a limited resource setting.
Thank you. And just for, there's a question which I would say that I would just answer. It is on what hope is there towards improving the access to these rapid diagnostics in low and middle income countries. And thank you for that question. We are making efforts to increase the access and actively working with doctors like all of you who are attending the session and the speakers on doing so. And if you're not able to answer any questions, like I mentioned earlier, please reach out to us directly after the session, and we will keep answering your questions. So till we have time, I will keep asking the questions. Dr. Walsh, there's one I would say is about how do the T2 panels support antimicrobial stewardship in your hospitals? And if time permits, Dr. Holbik, your comments also would be valuable on this topic. Dr. Walsh, mute, you're on mute.
So T2, from our own experience and certainly from the literature, there's expanding experience to demonstrate, and as we heard as well from Dr. Holbik, the potential and very real role for TP Biosystems to be helping in the antimicrobial stewardship mission. As cases in point, when we start broad-spectrum antimicrobial therapy empirically, antibacterial therapy empirically, we are clearly covering both gram-positive, gram-negative organisms. In waiting for blood cultures, which may take 24, 48 hours beyond, and sometimes may not even be sufficiently sensitive, we often are constrained in giving extended broad-spectrum empirical therapy, particularly if the patient is improving. But with the rapid turnaround, within 3 to 4 hours, if we can narrow spectrum, for example, and knowing that we do not have an enterococcus species, we don't have gram-positive organism, if we know that we have a gram-negative pathogen, that helps immensely in narrowing our therapy down to, say, the third-generation cephalosporin, ceftazidime, cefepime, or piperacillin tazobactam, without the use of vancomycin, and thereby sparing the selective effect for Enterococcus faecium. On the other hand, if we know that we clearly have MRSA and that comes up rapidly, we can then spare the exposure to potentially broad-spectrum agents, including even potentially carbapenem. So already we can see in a relatively short span of time, and especially in critically ill patients, that we can make clear decisions along the lines of gram-positive and gram-negative organisms. Paramount, though, to our management of critically ill patients, so also is the role for antifungal therapy. And for critically ill patients, we also strongly advocate the use of empirical antifungal therapy. With that, when we suspect candida, it's often in a kind of candida. In some institutions or in lower income, low resource institutions, fluconazole may be used. Either, regardless of whether we're using fluconazole or a kind of candida, there is a stewardship component of it that the longer we will use an empirical regimen without documented infection, that we run the risk of resistance. Emergence of the kind of candida resistance pathogens is a serious problem. The emergence of fluconazole-resistant pathogens, especially Candida glabrata, Candida krusei, is very, very well known. And therefore, knowing early that we have an albicans or tropicalis where we can rest assured that we're not looking at potentially resistant organisms is a very powerful stewardship tool. If we have negative cultures, the prior probability would suggest that that is likely going to be real given the high level of specificity. So I think in both for fungi, for invasive candidiasis, and for the common bacterial pathogens that we encounter in a critical care setting, stewardship can be enhanced by the TP Biosystem.
Thank you. Dr. Holbik, would you be able to help us with answering this, as well as if you can manage to help us understand that you did mention about the MDR pathogens testing that is done. So if you can help us understand if you have observed higher rates of MDR pathogens in the COVID patients with secondary infection compared to non-COVID patients.
Yes. I was typing in the chat earlier, but I'm a slow typer, I'm sorry. So as to MDRO patients, we did not see a spike compared to a usual population at the ICU. I think one factor of that is that we have been treating COVID-19 exclusively at our ward, and maybe it's Austrian luck. I think that we don't have that many multi-drug resistant patients in the normal general population, and for the normal population outside of COVID, this station is normally we are specialists in multi-drug resistant patients, so we get those who have multi-drug resistant organisms, and they are being sent exclusively to us. So as compared to the usual population, there's less. And I can also say that I think we have a very low number. I don't have the exact number, but we have a very low number of multi-drug resistant patients during the times of COVID for the last 1.5 years now. So by that we are blessed, I think.
Thank you.
And as for antibiotic stewardship, I think that, as Dr. Walsh also said, if you have the possibility to narrow down early with the help of T2, I think it's crucial to do that, and I think it's also saving resources and also helping the patient with, since most of these drugs are very toxic, so it's a good thing that to get the results really early on.
Thank
So
you.
rapid testing, I think, is crucial in that case.
Thank you so much. And I think if we have a little time, I don't know whether we'll be able to finish this, but there was a question on the clinical. I'm trying to look for that. The clinical indices. So which clinical indices were used along with these panels for the prediction of the incidence of bacterial co-infections?
Yes, I see the question. So mostly, I think the one major predictor was time at the ICU and previous antibiotic therapy. Also, patient history, if the patient has been in several hospitals, I think is crucial. And well, of course, if there is if the patient had got a course of high dose cortisol or stuff like that, so that the immune system is compromised, maybe during the COVID-19 therapy.
Thank you, Doctor. Doctor, there's just one more quickly, if we can. Are there any clinical application for a negative result? Like, did you see that in the patients? Any clinical application for a negative T2 biosystem?
Yes, if we were suspecting an organism that is covered with T2 bacteria and we do the control, then we are in luck, because we can say that since the sensitivity is very high, we can say that the patient is cleared. So that was nice. And also, if the first T2 panel was positive and the control a few days after was then negative, which this was also proof of therapy for us. But if we were completely sailing in the fog, then a negative sometimes gave us a headache. So
Thank you so much. Can we still be heard? I'm just trying to confirm. Can somebody say in the chat that we can be heard? Yes. Okay. Thanks, Melissa. Basically, is something, Dr. Holbik, you could share more on the T2 panels improving the outcomes, like you did mention briefly, and Dr. Walsh, I think this is a very important question, whether T2 panel helped improve outcomes in the facility, specifically for COVID patients, since we're discussing that.
I think that one major point is that we have seen several patients with Staphylococcus aureus infection, and also with Enterococcus faecium. So with Enterococcus faecium, which is covered by T2, it was very, very good to see, and also Klebsiella and Staph aureus, of course, that was the result early on, so we can hit them hard and don't have to be broad, because we thought maybe there was some Pseudomonas in the patient, and well, that was in this case T2 was good for the patient outcome. But well, in some cases, if as I mentioned earlier, if everything came back negative, then yeah, but I think that's the normal course.
Thank you.
I hope I answered sufficiently.
Yes, and if Dr. Walsh, you have any comments to make, and after that, we'll soon be closing this session.
Yes. So in a broader context, we have seen from our preliminary data improved outcome in patients with invasive candidiasis. The number of cases of COVID-19 in Candida within our institution have been relatively small. I think in part that's been related to our meticulous antimicrobial stewardship and the prudent use of antifungal agents. But in the broader context, we have seen improved outcome, and we are endeavoring to expand that database in order to fully consolidate that indeed with Candida we've been seeing significant improved outcome. And with regard to our COVID-19 patients, in general, the central principle remains, and this is across the board throughout the literature, both in the COVID setting and in the non-COVID setting. Early detection and therapeutic intervention improves survival. It improves survival for Candida. It can be measured by hours. It improves survival in patients with bacterial infections. So if we know that we have a definitive organism, whether it's in COVID or outside of COVID settings, and if we can identify those early and target therapy earlier, outcome can be improved.
Thank you. Thank you. Thank you to our chair and the speakers for all the question and answers. And we can also keep taking the questions later. The session is coming to an end. I did launch a poll, and so please answer that. That is for the participants. And I would like to conclude the session. Dr. Sinha, would you want to say something? And actually, you can also look at the poll results. And towards the end, if there's time, we can tell them, or I'll try to put it in the chat. But somehow I'm not able to send it to the chat. Dr. Sinha, would you want to say something, please?
Yeah, thank you very much. I would like to thank the speakers and also the audience for their attendance, and the speakers for the contributions and the lively discussion. And I think with this, we can close the session. Thank you very much, and have a nice last day of ECCMID.